Good morning and welcome to our review class. At this moment, I'm going to start with my discussion on surgical diagnostics. Always remember that always study on the different uses of diagnostic tools. This is very important in answering your questions in the Philippine Board of Surgery. Now, a quick look about the latest technology on CT scan. I would like to introduce to you the 1152 slide CT scan. This is available in St. Luke's. This is very fast, more accurate, clearer. And the good thing about this is when you put your patient inside the gantry, and just after 10 seconds you will be able to see the images already. So this CT scan is very fast, very powerful, especially important in patients who had trauma. Another latest technology is the 3.0 Tesla MRI, also available in St. Luke's. This is very fast and it gives clearer images of the different parts of the body. So if you want clearer image, fast imaging, okay, you can look for this kind of equipment. Now, PET CT scan is always being discussed in several lectures, several discussions. So PET CT scan stands for positron emission tomography computed tomography scan. It utilizes glucose tagged with radioactive material. This glucose will then go to the area of the body with highest sugar metabolic processes. And this include the tumors, include TB lesions. So it's very important to differentiate between cancer and TB. By the way, in St. Luke's, we have this cyclotron, which produces the radioactive material. PET or PET scan is a diagnostic examination that involves the acquisition of physiologic images. Please take note of this. Physiologic images. Uses 18F fluorodeoxyglucose taken up by glucose using cells and phosphorylated by hexokinase. Mitochondrial form is greatly elevated in rapidly growing malignant tumors, meaning this glucose is being taken up by malignant tumors. This is the PET scanner, can be used for cancer screening. Sometimes patients will ask you to request for them PET scan in order to know if there are malignant tumors inside the body, or just after treatment for cancer, they wanted to know if there are metastases in other parts of the body. And sometimes it can also give some details of the anatomic changes happening inside the body, which may connote cancer. As you will see, this is the CT scan of the patient, PET scan, and if you combine the CT scan and the PET scan, you will have this image, which is clearer compared to PET scan, compared to CT scan. Mhm. This is the combined image of these two modalities. Because sometimes you see some nodules in the body and you don't know if this is cancer or not. But when you check it through PET CT scan, you'll notice that there will be lighting in this area. Another patient with cervical node with metastasis. Okay, that's a metastatic cervical node. Okay, PET scan, CT scan, and PET CT scan. In the PET CT scan, you show some blackish material in this area. In CT scan, you don't see it. Okay, you don't see it like in this area. You don't see it in CT scan. But using PET CT scan combination, you will be able to see the affected lymph nodes. Now we go to the hepatobiliary system. Um, in patients with hepatobiliary problems, we always ask for several diagnostic tools in order to diagnose our patients. For the non-invasive diagnostics, of course, we have ultrasonography. You should know the indications for using this equipment. Oral cholecystography, this is for uh, cholecystitis, although recently we don't use this anymore. HIDA scan for cholecystitis also, or for any obstruction in the biliary tree. Computed tomography with IV contrast is very important. And of course, MRI, magnetic resonance imaging. For oral or intravenous cholecystography, there will be ingestion of organic iodine compound and will be able to identify filling defect inside the gallbladder if there will be a stone. But as I have told you, lately we don't use this anymore. Way back during my residency days, way back 1990s, I saw some procedures which use this kind of radiologic test. Now, for HIDA scan, please also read for HIDA scan because this might be asked in the board exam. And with HIDA scan, it is a nuclear imaging technique. HIDA scan is used to verify if there will be an obstruction in the cystic duct, which may give us an idea of an acute cholecystitis. So if the gallbladder did not show any HIDA inside the lumen, so most probably you are having a patient with acute cholecystitis. So this is non-invasive, although um, probably the last time I used this was probably about 10 years ago. Okay. Now, for computed tomography with IV contrast or with triple contrast using oral contrast or rectal contrast, this might help you to identify liver tumors, either benign or malignant. I know you know the indications for using computed tomography for hepatobiliary lesions. As you will see in this plate, there are multiple masses inside the liver. This is very important if you are planning hepatic resection. Okay, very important. you go to the radiology department and review the plates together with the radiologist for proper planning of surgery. Now, probably you have encountered endoscopic retrograde cholangiopancreatography. In some institutions, they don't have this kind of technology, but what is very important about ERCP is this. You are able to do biopsy if there will be some lesion or tumor in the periampullary region, especially those inside the lumen of the small intestine. Second, with ERCP, you are able to inject a dye in the biliary tree to know the site of obstruction. And third, you can also put a stent in case of patients with biliary obstructions. And sometimes the gastroenterologist can also remove the stones in the distal common bile duct. ERCP, I always ask this before doing laparoscopic surgery in order to clear the biliary tree so that during surgery, I'll not do intraop cholangiogram because it is tasking and sometimes very hard to do. Okay. The problem with ERCP is sometimes they might produce acute pancreatitis. With regards to ERCP, it is the gold standard for detecting common bile ducts. It is both diagnostic and therapeutic, invasive, and carries a risk for complications like acute pancreatitis, perforation. Now, MRI or magnetic resonance imaging is very, very important in hepatobiliary surgery. Why? Because it will give you clearer images. Second, if you have a suspicious lesion in the MRI, and this is associated with increased alpha fetoprotein in the blood of the patient, then most likely you are already dealing with a liver cancer and you don't need to do liver biopsy. Another function of MRI is in the field of magnetic resonance cholangiopancreatography. You give a dye to the patient and this dye will go to the hepatobiliary tree, and using MRI, you will be able to see any obstruction in the bile duct, especially in the common bile duct. If you are suspecting uh, stones or if you are suspecting periampullary tumors. It is useful for detecting common bile duct stones and other abnormalities in the biliary tree. Extremely sensitive in detecting biliary tract cancer, and it is non-invasive, a good alternative to ERCP. Okay. Sometimes ERCP is negative, but when you do MRCP, sometimes they show stones in the biliary tree. Let's go with percutaneous transhepatic cholangiography. This is performed by our interventional radiologists, and they will inject a dye in a dilated biliary tract or biliary channel. It is performed under sonographic or CT guidance, and they will inject a dye in order to verify if there are obstructions or lesions in the biliary tract. The problem with this is invasive. Second, you need to check for the pro time. bleeding parameters because most of these patients are cirrhotic, jaundice, and we don't want to have bleeding intraoperatively or postoperatively. With regards to triple contrast CT, okay, triple contrast CT, it employs injection of intravenous dye together with oral and rectal contrast material. It is very helpful, especially if you are suspecting lesions in the GI tract of your patients. As I have said earlier, ERCP is very good procedure if you are planning to put a stent in the common bile duct, because sometimes you cannot do the definitive procedure because of jaundice, because of cholangitis. You have to drain the biliary tree. So if you are planning to do a Whipple procedure, okay, before before doing the Whipple procedure, you remove the stent intraoperatively. Let's go now to the breast. Probably you'll be asked so many questions on the breast topic. And for the breast, we have mammography, ultrasound, MRI. In my personal practice, normally I ask for mammography and ultrasound together because sometimes you cannot see lesions in mammography but can be um, seen in ultrasound. I ask for ultrasound mammography for patients 35 and above. But for screening, I ask mammography ultrasound every 2 years at the age of 40 to 50, 50 and above every year. MRI is very powerful. I ask this if the patient requests um, for this screening strategy. Okay. Before you take the board exam, it's very important that you know the different BIRADS categories. Okay, if the 0, 1, 2, 3, 4, 5, 6. If you don't know this, probably are not prepared to take the board exam. Please memorize this table by heart because you might be asked that your patient having BIRADS 2 or BIRADS 4. So you know what is the meaning of the question. For the breast, we don't do fine needle biopsy anymore because we have the core needle biopsy apparatus, or if you want a bigger chunk of tissue, you can proceed with incision or excision biopsy. For core needle biopsy, I'm very comfortable with gauge 18 up to gauge 14. Okay, but you can use also gauge 16. Follow your preference. Okay. Mammography is not 100% accurate. There's a 10% chance that the reading is wrong. So learn how to read mammography plates. Look for architectural distortion. Look for microcalcifications. Look for concentration of microcalcification in a 1 by 1 centimeter area. You should know the characteristics of benign and malignant lesions. For ultrasound, We use this to know the location, to know the consistency of the tumor, whether it is cystic or solid. We also use ultrasound to help us during our ultrasound guided biopsy. As I have said, MRI is a very powerful machine. However, it is not very cost effective because it's pricey, and sometimes not all hospitals in the vicinity have this MRI machine. We can request MRI in patients who are having this prosthesis. Okay, it's very hard to compress the breast with mammography. Please take note that it is not a replacement for mammogram or ultrasound, and it is used for high-risk women because it is more powerful, I believe, compared to mammography. There's a new equipment. This is tomosynthesis mammography. On your left side, we have the usual digital mammogram, but using tomosynthesis, this is a 3D mammogram. You will have clearer picture of the breast. Although only few centers have this equipment, if you see tomosynthesis in the exam, just remember it is a higher form of mammography. Again, you compare the digital mammography to the image of tomosynthesis. You are able to identify the presence of a suspicious lesion. We have also elastography, and we look for the elasticity of the tumor. If after using elastography, you see green lesions, more or less, these are benign lesions. However, if you see blue lesions, most probably, these are malignant lesions. Elastography is available in perpetual, and I think this is also available in Jose Reyes Memorial Medical Center in Manila. Mm, we know how to biopsy. Fine needle aspiration biopsy, probably you can do this if core needle biopsy apparatus is not available. But of course, expect lower accuracy with FNAB. This is core needle biopsy, and the good thing about core needle biopsy, preoperatively, you can get a bigger chunk of tissues for estrogen receptor, progesterone receptor, and HER2 new. This is me performing a core needle biopsy, and you will see in this picture a bigger chunk of tissue compared to FNAB, which is just a bloody smear. For the breast, as I have told you, you can use ultrasound for non-palpable lesions used for core needle aspiration biopsy, and it is not designed to remove the entire lesion using the core needle biopsy because for that, we have the mammotome machine. Please read on sentinel lymph node biopsy. This is very important in your exam. It might be asked in head and neck tumors, breast cancer, lymphoma, penile cancer, squamous cell carcinoma, and we also have this technology, which is mammographic needle localization biopsy. This needle is being inserted in the breast center. Please remember that in mammographic needle localization biopsy, this is performed among patients with non-palpable microcalcifications, non-palpable small tumors. We also have mammotome, and we aspirate tissues. We get big chunks of specimens. But the problem with mammotome aspiration biopsy is sometimes doctors will encounter post-operative bleeding. Okay, there will be some pain in the operative site. But the good thing about this is the surgeon can aspirate all the suspicious tumors for better pathologic determination. So please read on mammotome. Another technology is stereotactic breast surgery, wherein we employ computers in order to get the non-palpable lesion through a core needle biopsy apparatus. The patient is in a prone position. Also read on this kind of technology. Now we go to the head and neck. We normally employ ultrasound for head and neck tumors, especially thyroid gland. For the panorex view, it is a two-dimensional dental X-ray that displays both the upper and lower jaws and teeth in the same film, detecting benign and malignant lesions of the mandible and detecting oral cancer and cortical bone involvement. This is very important for patients with mandibular or gingival tumors. However, probably you will, I don't know if you will be asked on this topic in the board exam, but it is nice to know, no? We employ computed tomography, magnetic resonance imaging. We know how accurate MRI imaging, especially in head and neck tumors. Sometimes we need to refer to our ENT friends for nasopharyngo laryngoscopy. This is very important for sinus openings, the larynx, and the vocal cords. Sometimes we see patients with enlarged lymph nodes, and we suspect nasopharyngeal tumor, so we refer this to our ENT friends for nasopharyngeal biopsy or nasopharyngeal blind biopsy. They are able to perform fine needle biopsy, punch biopsy in these areas. Sometimes they do biopsy also of the tonsillar region. Now, for the sestamibi scan, this is employed uh, among patients with possible parathyroid hyperplasia, parathyroid adenoma. Mhm. So if you see uh, a black area in the area of the head and neck, most probably it is a parathyroid adenoma. Thyroid scan is also being requested to verify if your patient has hyper or hypothyroidism, or if your patient has a hot nodule or a cold nodule. When we see hot nodules, there is a very, very small chance only of having thyroid malignancy. But if you see a cold nodule, there is a higher chance of thyroid malignancy. And of course, we request for a whole body iodine scan among patients who underwent total thyroidectomy to verify if there are metastatic sites coming from the well-differentiated tumors we remove in the thyroid gland. Normally, this is being requested 6 weeks after total thyroidectomy. For the upper gastrointestinal tract and small intestines, of course, we request for upper GI endoscopy. Very important to see the lumen of the esophagus, to see the lumen or the mucosa of the stomach, duodenum. We request this to be done by our gastroenterologist. For the radiologic test, sometimes we employ this for lung tumors, esophageal tumors, okay, for barium swallow, very important. In barium swallow or contrast studies, we see patients with diverticulum, fistula, or if there are any strictures secondary to acid or base ingestion. Computed tomography is very important for patients with esophageal cancer, upper gastrointestinal tumors, gastric cancer. There are some gastroenterologists who are also very good with endoscopic ultrasound. With endoscopic ultrasound, we are able to verify the depth of the tumor, if there are lymph node involvements. If you are suspecting ascites, you can see this in endoscopic ultrasound. And the good thing about endoscopic ultrasound, you can do biopsy of the tumor or biopsy of the surrounding lymph node or lymph nodes. This is endoscopic ultrasound. This is available also in St. Luke's Medical Center. For colorectal, we know the importance of colonoscopy, sigmoidoscopy, anoscopy. So you should know the different indications for requesting these procedures. With regards to capsule endoscopy, this is very important to know the mucosa of the small intestine because, of course, we cannot see it through colonoscopy, through upper GI endoscopy. However, capsule endoscopy is not available in the Philippines. I know, no? I don't know if there are institutions who have this capsule endoscopy. In the US, when I rotated in the US, this is available in Columbia University Medical Center. Uh, what we do in capsule endoscopy, we let the patient take a capsule and it has a camera, and through this capsule, we can see images of the lumen of the small intestine, also lumen of the stomach, lumen of the and mucosa of the large intestine. Okay, these are the imaging studies. We have plain X-rays, computed tomography, virtual colonoscopy, MRI, angiography, and however, ultrasound, we seldom use this for colorectal tumors. Probably if we are suspecting liver metastasis, we can employ ultrasonography. Please take note that if you have a rectal cancer, it's very important to request for an endorectal ultrasound in order to verify the depth of the tumor, extension of the tumor, if there are lymph nodes in the mesorectum. Our colorectal surgeons are very good in performing endorectal ultrasound. Okay, you will be able to know the different layers of the rectum. You will see involvement of the mucosa, submucosa. Mhm. However, there are some limitations, especially if there is an obstructing lesion. You cannot put the probe further inside the rectum. It is a user-dependent imaging modality. The gastroenterologists, the radiologists, and the colorectal surgeons are very good in performing this procedure. Um, Now, MRI is very good as an adjunct diagnostic modality, especially if you want to know the extension to the mesorectum, to the pelvic side walls, because endorectal ultrasound is very limited with regards to studying the depth of the tumor and involvement. It is more sensitive than CT scan in detecting bone involvement or pelvic sidewall extension. But remember, if you want to request for MRI, you request for rectal MRI with rectal coil. Okay? Very important for clearer view of the rectum and mesorectum. And if you are suspecting any lesion with bleeding inside the colon or GI tract, you may ask for angiography being done by our interventional radiologists used for detecting bleeding in the colon. But remember, the bleeding should be 0.5 to 1 ml per minute. Sometimes we cannot see the bleeding by arteriography. For minimal bleeding, we can request for technetium-99 RBC scintigraphy. However, based on our practice, we request this for patients with Meckel's diverticulum, which is bleeding. This is very good for that kind of problem. Okay, so please remember the difference between arteriography and scintigraphy. Read on this. This is virtual colonoscopy using CT scan. And the good thing about virtual colonoscopy or virtual colonography, this is not invasive because you are just using a radiologic technique. The problem is you cannot do biopsy. The good thing, however, is less chance of perforation, of course, because I have seen patients who underwent colonoscopy who had perforation of the rectum. So there are pros and cons using virtual colonoscopy. Please, if you are not very familiar with these tools, read on this diagnostic test furthermore in your readings, using Google, using your books. Now we go to the extremities. We see patients with peripheral arterial diseases, black toes, non-healing wounds, okay, pain in the lower limbs while walking, non-healing diabetic foot. So we request for arterial duplex scan in order to see the health of the arteries in the lower limbs. In some patients, you will encounter people with chronic venous insufficiency, non-healing ulcers, edematous legs. If you have this kind of patients, you request for venous duplex scan. Now, we go to bone metastasis If we are suspecting bone metastasis, we request for bone scan. You will encounter some readings saying arthritis versus metastasis. If you have this situation, you request for alkaline phosphatase. If this is elevated, it might be due to bone metastasis, especially if you request for an MRI of that area and there are lytic lesions. Most probably you are dealing with bone metastasis. And bone metastasis, it means your patient is stage 4 already, and she might need, or she might require, or he might require chemotherapy treatments. And if you see unstable metastasis in the vertebral column, or if you have pain in this area, you request radiotherapy treatments in order to stabilize the bones and decrease the pain of your patients. Also read on immune staining, the importance of these stains in diagnosing different kinds of diseases. Study tumor markers. For the breast, we don't have any tumor marker. For liver cancer, alpha fetoprotein. Pancreatic cancer, CA125. If you have an elevated CA125 associated with a pancreatic tumor, most probably this is cancer already. Ovarian cancer, we have CA125. Stomach cancer, CEA. For the GI tract, we have CEA. For the colon, very important to ask for CEA determination before surgery. For prostate cancer, we have PSA, testicular cancer, AFP, and HCG. My take-home message is this: use surgical diagnostic tests as needed. Choose the best test. Very, very important. And with that, I wish you all the luck so that you will be able to pass your examination. Good day to everyone.